Welcome, everyone, back to the Neonatal Cardiology Curriculum Series. This is Sean Sen. Today we'll be going over Tetralogy of Fallot. I have no conflicts of interest. So today we'll be going over some of the anatomy and pathophysiology of Tetralogy of Fallot. We'll be reviewing the spectrum of neonatal clinical presentation, as well as we'll review the etiology of hypercyanotic or TET spells and the strategies that we would use in the ICU to treat. And then lastly, review the goals of complete repair, as well as what surgical options there are, and go over the surgical technique as well. So Tetralogy of Fallot probably is something that we've learned since medical school with fun little mnemonics. But the classic for tetralogy is pulmonary stenosis, right ventricular hypertrophy, a ventricular septal defect, and an overriding aorta. And then the other thing that we always remember is that there's a boot-shaped heart that typically is associated. Well, I want to take a little bit further and really kind of describe what Tetralogy of Fallot is from an embryologic standpoint. And what it really boils down to is really a monology of Fallot. It's actually all related to a single defect, and that defect is really a malalignment defect. And the best case scenario, if you think about it, is imagine if you were building a railroad from North Carolina and from California, and you met somewhere in the middle of Oklahoma, and all of a sudden you get to the point and there is a malalignment, and you realize that there's a gap in between those railroad tracks. And that's exactly what we see with Tetralogy of Fallot. In the case where the malalignment actually occurs when the interventricular septum is being made. And so malalignment VSDs aren't a deficiency of the ventricular septum, but instead it's a defect within the septum when it's formed. And so embryologically, the muscular portion of the VSD grows from two different areas. So there's one that's coming from the apex of the heart that normally meets with the conotruncal portion of the ventricular septum. And so in situations where the connection does not meet appropriately, the result is this malaligned defect. And so the conotruncus, if you think about it, typically if there's an anterior malaligned defect, so if you can kind of picture the top railroad track, the conotruncal portion of it, if it's coming towards you out of the page or out of the presentation here, it pushes that anterior pulmonary artery. And so what you end up having is, with an anterior malaligned defect, it pushes that pulmonary artery, resulting in pulmonary stenosis. It results in a larger aorta, the posterior part of it, so you have an overriding aorta, and then you have this gap where you have a ventricular septal defect. And so that's really the etiology of Tetralogy of Fallot. When we look at the epidemiology, it's about 4 to 5 per 10,000 live births. It is a fairly common congenital heart disease, about 7 to 10% of all cases. It doesn't have a preference between gender, and genetically there is an association with DeGeorge. And so if you do have an infant with the diagnosis of tetralogy, it would be important to do a genetic workup. Chest x-ray findings, as mentioned, it's the typical boot-shaped. This actually came from France. It was termed Cour and Savot. Horrible saying it, but really kind of talking about those clog-shaped shoes and its resemblance to that. But when you look at it, the reason why is really because of that right ventricular hypertrophy that results in that upward displacement of the cardiac apex, as well as you have this concavity of the pulmonary artery trunk, and then overall you get that sort of clog or boot-shaped heart. The other important thing to look for in the lungs, sometimes we look at the lung vasculature, and if you can look at it, it looks very dark. And the reason and the term for that is oligemic. or the fancy term for it. And what we're really seeing is poor pulmonary vasculature, or because there's so significant pulmonary stenosis, oftentimes you'll see this dark appearance of those lung findings. When we think about Tetralogy of Fallot, it's not just pulmonary stenosis, but it really is a multi-level obstruction, and it starts all the way in the subpulmonic area, or sometimes also known as the infundibular area or the infundibular muscle. And so that right ventricular outflow tract, you can see obstruction there, along with you can see valvular stenosis. And so depending on the type of lesion, you can see dysplastic valves, you can see thickened membranes, bicuspid narrowing, and the annulus also to be significantly small. And then on top of that, you can also see supravalvular stenosis, again, where you can see it in the main pulmonary artery, as well as all the way extension up into the branch pulmonary stenosis as well. RVOT, so the right ventricular obstruction, we talked about how this can play a pretty significant role. There's different types. You don't really need to know all the different variations, but just know that why and the importance of having that right ventricular outflow tract obstruction. And then similarly, that not only is there pulmonary valve stenosis, but that there can be different morphologies for it. So you can see anything from varied thick membranes with a small opening. You can see a bicuspid versus tricuspid, as well as thin membranes and then thickened sort of those leaflets. And this poses importance when we're talking about surgical options for how to treat that pulmonary stenosis, which we'll talk about later. So as a neonatologist, I think it's really important to understand Tetralogy of Fallot from a clinical presentation. And neonatal presentation is really dependent on that degree of pulmonary stenosis and RVOT obstruction. So when we think about sort of a spectrum of cyanosis, in its mildest form, if you have mild pulmonary valve stenosis with very mild RVOT obstruction, you really don't see much cyanosis, or really, from a physiology standpoint, what you're really dealing with is a VSD physiology. And so, sometimes this is coined a pink tet, and this is exactly what that physiology would be like. As you start to talk about more pulmonary valve stenosis or a moderate RVOT obstruction to severe pulmonary valve stenosis and RVOT obstruction, these are the patients that you really do need to watch out for acute obstruction, cyanosis, and sort of the spelling TET. And then on the far end of the spectrum, where if you have complete pulmonary stenosis or pulmonary atresia, these would be patients that are completely ductal dependent early on in life, mainly as there's no other source of pulmonary blood flow other than the duct itself. When we talk about delivery room management, it's important to know if there's prenatally diagnosed the degree of pulmonary valve stenosis, and so that would be very helpful to know early on. If there is significant cyanosis at birth, when in doubt, this would be an infant that starting PGE wouldn't hurt. And then in the presence of persistent pulmonary hypertension or that delayed transition, you may have right to left shunting at that VSD level. And so as an early indication of cyanosis, trying to relieve the pulmonary hypertension and trying to understand that physiology, it's important. And then lastly, again, on the other side of the spectrum, when you do have a pink TET, it's important to avoid using oxygen for long periods of time, or even using it in high doses, and mainly, again, because what you're dealing with is a VSD physiology. And in that case, you're doing more harm in that scenario by giving oxygen and promoting more pulmonary blood flow into the lung space. So, what is a hypercyanotic, or what is a TET spell? And so, a TET spell is really, periods of profound cyanosis that results in almost total RVOT obstruction. The resulting physiology you end up having because of that occlusion or high vascular resistance in the pulmonary bed, you have right to left shunting at that VSD level. And so you end up having cyanosis. You have decreased pulmonary blood flow, which also promotes cyanosis. And then you ultimately, this precipitates acidosis, which then leads to further pulmonary vasoconstriction and pulmonary hypertension, which then causes more cyanosis. And you can see a vicious cycle once these hypercyanotic spells can occur. Here's an example of, on a cath, to really kind of appreciate what dynamic obstruction actually really is. And so this is a cath angiography showing the right ventricle. You can see in the white arrow the main pulmonary artery as well as the branch pulmonary arteries. And there really is multi-level stenosis. You can see at the level of the valve, which is where the black arrow is. You can see also stenosis by the red arrow at the bifurcation of the LPA and the MPA. And then more importantly, during systole, you actually have complete obstruction in that RVOT during systole. And so that's by that little asterisk, red asterisk. And this is really what's termed dynamic obstruction during systole. So how do you treat hypercyanotic spells? And so I like to think about, I don't have a fun acronym, but I like to think about it in sort of these clusters. As you start to have your first initial treatment, or if you have further persistent cyanosis, I would sort of work your way down through this treatment strategy. And so the first things to sort of break a hypercyanotic spell is typically to give oxygen, which again, in this case, what you're trying to do is promote pulmonary vasodilation. And so in this case, the knees to chest position, or sometimes in older kids, what you may hear of the squatting position, really sort of increases your systemic vascular resistance. And when you're increasing your systemic vascular resistance and that systemic afterload, you're sort of pushing or promoting pulmonary blood flow into towards the lungs. Morphine, the mechanism of action is a little unclear. The way I interpret is that in the off chance that when you are cyanotic, you're also agitated and you're crying and you're making things worse. And morphine can be something that causes overall this, sort of some vasoplegia and relaxes the lung bed as well. A fluid bolus in this case would also be helpful in terms of improving that right ventricular filling. Many of these Tetralogy of Fallot, they'll have stiff hearts from the right ventricular hypertrophy, and so they are preload sensitive. And so being able to adequately provide good preload, which would help stretch that RV and promote more blood flow towards the lungs. And then again, when you have more significant episodes, things like phenylephrine, which would again increase your systemic afterload, acutely increase your systemic afterload, which would hopefully promote right ventricular blood flow into the pulmonary circulation. And then also a beta blocker, which could potentially slow the heart down and also potentially allow more filling time of the heart so that it can also be fluid preload sensitive. Again, with the beta blocker, I would also be just conscientious of what those blood pressures are, but it is an option as well. So what about the complete repair goals? And so, if you think about the anatomy and physiology, the goals of repair are really to relieve that RVOT obstruction. You want to have complete separation between the pulmonary and systemic circulations to close that ventricular communication. You want preservation of that RV function, and so really trying to look at what the degree of RVOT obstruction there is. If there's significant vascular resistance, there would be a stress to that RV. What can we do to sort of relieve or dilate the branch PAs, the systemic, suprasystemic, the valve, as well as the RVOT? And then minimize any sort of post-procedure pulmonary valve incompetence. And we'll talk a little bit more about the pulmonary valve insufficiency that may come about with the repairs. The timing of repair, generally, there's a goal to have a full repair at about 3 to 6 months. It's depending on that severity of RVOT obstruction, where you may need to do earlier intervention. There are palliative options, which we'll talk a little later as to what would be some indications or contraindications of complete repair. But options including a BTT shunt or a ductal shunt to help create a more stable pulmonary blood flow. And then thinking about a later date surgery. The risk of surgery beyond 1 year of age generally talks about the risk of pulmonary hypertension, similar to VSD physiology, where you have extrapulmonary blood flow and shear stress that's ultimately causing remodeling changes for long periods of time. There's unfavorable RV remodeling as well when you have systemic RV pressures or suprasystemic RV pressures. And then ultimately, at time points that are beyond that 1 year of age, you can also have risk of ventricular arrhythmias. So the surgical option, when you think about all the three different areas of obstruction, I think it's important to know what are those options. And so from a supravalvar standpoint, obviously pulmonary arterioplasty or some sort of patch augmentation. At the valve level, doing a valvotomy with plus or minus balloon or a balloon dilation. We'll talk a little bit about what the transannular patch is. And then again, if there's infundibular or subvalvar muscle hypertrophy, to have areas where you can resect that muscle bundle. So the approach is generally can be done transatrial. It can also be done transpulmonary. Very rarely, it can also be done with an RV ventriculotomy, knowing that a ventriculotomy does cause a higher risk of ventricular arrhythmias because you're cutting into the ventricular muscle. And when you think about sort of options of how to augment that pulmonary valve or that pulmonary artery, you can think about options including transannular patch or an RV to PA conduit. This is a nice video from Cincinnati Children's that goes and reviews a little bit about what that patch repair looks like, or what the repair looks like. This is an example of a transannular patch, and so here, you can see from the inside of the RV the area where the inflow is, and then the outflow where the infundibular septum has just been resected. There's a patch that's used to close that VSD. And then looking at it from a pulmonary artery standpoint, the pulmonary artery is opened up, and areas where you can examine that pulmonary valve. If there is further pulmonary outflow obstruction, that can be fixed. And then to augment that pulmonary valve, you can use a transannular patch, which opens up that entire pulmonary outflow tract. So this is just the same thing, but in a more of a diagram form. I like pointing it out to look at what the pulmonary valve would look like on FOSS, and you can see where that transannular patch goes. What you end up having is an area of the pulmonary valve where they never coapt, and you end up having insufficiency. And so one of the big issues with any sort of transannular patch repair is that you're going to have free pulmonary insufficiency or free PI. And early on, the RV can handle that extra volume that's coming back with each systole. But with time and monitoring, it's important to know how much that RV is getting dilated. And if there's any point where down the road you would actually have to repair by putting in a prosthetic pulmonary valve or some sort of pulmonary valve. So there are newer techniques that include valve sparing repair. Some of our neonates can undergo this, and really this depends on whether or not there's adequate pulmonary valve annulus size. And so, again, if the annulus is big enough and there's options to do this, this can be done as a surgical option where the integrity of the valve is spared, and so you end up having a functional valve. Considerations for palliation, what are some contraindications of a complete repair where we would have to think about palliative approach? Obviously premature infants who still need to grow, who are at high risk for pulmonary bypass. Significant comorbidities would also fall in that category. Tetralogy of Fallot has a higher risk of coronary abnormalities. And so one specific coronary abnormality that's common is an anomalous left anterior descending coronary, and that may come across that RVOT. And so in situations where the anatomy would, the coronary anatomy would prevent you from making any sort of cuts along the RVOT, that would be catastrophic, but that would also be a contraindication. And then again, really, from a neonatal period, it's important to note that residual branch PA stenosis is very poorly tolerated in that neonatal period. And so especially if a transannular patch was performed where you have a free PI, a volume overload, as well as significant RV afterload. So what to follow up after tetralogy of Fallot repair? Things that we look out for, residual RVOT obstruction, progressive RV dilation, and RV dysfunction as mentioned from the free PI. There's a higher risk of late ventricular arrhythmias, pulmonary insufficiency, as well as RV dilation. From a counseling standpoint, especially if you have a preoperative neonate that's has a tetralogy of Fallot physiology, it's important to know that the risk of reintervention is there for primary tetralogy of Fallot repair. And this was a study that looked at 100 patients where about 30% of them over a 5-year period needed some sort of surgical reintervention, and about 50% of them needed some sort of cath intervention. So take-home points, tetralogy of Fallot is an anterior malalignment defect that ultimately results in the remaining 4 tetralogy, VSD, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. The clinical presentation is really dependent on that degree of pulmonary stenosis, and infants with dynamic obstruction really are the high-risk patients for developing hypercyanotic spells and should be followed very closely. Thank you.